Welcome to another edition of Public Health Biographies. As you know already, will feature scholars and activists who have shown their eminence and excellence on their professional journey. I am K. Rajshekharan Nair, and my co-anchor is Dr. Mohammed Shaki from the University of Boston. And today, we are happy to welcome Professor T.K. Sundari Ravindran, former Professor Achyuthamenon Center for Health Science Studies, Sri Chitra Tirunal Institute for Medical Sciences. And she's also Principal Visiting Fellow, International Institute of Global Health, United Nations University, and visiting faculty to a number of institutions and a member of a number of UN task forces. I welcome you to this series, and let me start straight away. You are a PhD in applied economics, and it's a very difficult area for most of us, as it involves a lot of techniques and methods and all that, and concepts. But we are interested to know how did you shift to public health, and how did you develop an interest in public health? Because I mean, it's a great shift for many economists to move to public health, and at that time when it was only a developing field, and we are interested to know this initial shift that you did, I mean, in your career.
Thank you, first of all, for this opportunity to speak to a lot of researchers and scholars. And let me start off with letting you into a secret. My training in economics was only in MPhil and PhD. And both my interest in public health and interest in applied economics had a common root. This was my involvement as an adult educator and an educator of children who were out of school in the Dalit communities in Chengalpet district in Tamil Nadu. That's what I did after I did my master's in mathematics. I was working in the rural areas, and one of the things I had observed was that caste played a major role in the everyday lives of people in the villages, including in the economy. And that then led me to CDS, which was allowing scholars from other disciplines to study and research in applied economics. So that became my PhD topic, which was the role of caste in the rural economy. It's the same base, the lives and livelihoods of the Dalit communities in that place, that also brought me to public health. So I'm talking about 1978, 79, and Dalit communities then were living in separate colonies in the villages. And we were implementing adult education and children's education programs there. And their life was a misery, and illness was an everyday feature. And there were some heartbreaking moments. There was one instance where several children died of measles in a colony. Even when measles vaccination had already started being given in general, you know, at that time, but none of these children had been vaccinated, no health worker had come to their area, and so on. So there was a common root to the interest in both, and I never intended being an applied economist the rest of my life. I had already started working in the community. While I was doing my PhD, I shifted to working in the community on health, which then, you know, developed into an interest in public health. One of the major influences in terms of the academic orientation was a book that I came across quite by chance at that time, was called The Political Economy of Health by Leslie Doyle, which made the connections between the economic structures and the political structures that marginalized entire communities and the health issues and health inequities that these communities faced. So broadly, that's where, the motivation came from.
Well, you are known as an expert in reproductive health, gender, of course. As a field of studies in public health, I think now this is a more evolved area of studies and a lot of work in the area of gender. And it's a very important field also. But how you started this interest? And was the trajectory very smooth? It means at that time, the family planning ideology or the family planning control ideology was extremely strong. I mean, in the 80s and 70s and 80s, and it took a lot of time to change to a more integrated perspective of gender and the reproductive health and all that. The term itself was, I mean, quite difficult at that point of time to absorb to many people. Can you narrate your experiences, I mean, on this?
Yeah,
this
I think again I'm going to say it came from the field. The main thing was again, I was in my early 20s and I was working with a group of adult education teachers, women who were also very young. There were only a handful of high school educated women in each village. And in their everyday life, one of the big issues was domestic violence. And the second big issue was their fear of unwanted pregnancy. And the third was the way the health system was chasing women for family planning targets. So it was encountering on an everyday basis and discussing with women from that Dalit community about how they grew up to view their bodies with shame, how everything about their lives, how much they could study, whether they could have a job, who they had to marry, when they would have children. None of this was in their control. It was controlled by their families and the society at large. The women did not have any information about contraception. They did not even know how babies were made in terms of, they didn't know they had a womb. They didn't know how delivery took place and so on. And this general feeling of helplessness that people have because of no control over sexuality and reproduction made a very, very deep impact on me. And I remain convinced that gender equality will be impossible unless women have right to make these decisions. And even today, I think it is being studied. I don't know to what extent from the perspectives of lived experiences and the power dynamics that come into play when you talk about sexuality and reproduction. Much of it is about programs and how they work and what they deliver. So, yes, and in those days, it was the time of the population control was in full swing. So it was so unfortunate to see that on the one hand, women desperately needed information on contraception. On the other hand, what they had available to them was this high-handed are you coming for sterilization or are you not? Kind of approach from the government. And that is what brought me to this entire area of sexual and reproductive health and rights. And I believe that it's an issue for every woman in this globe.
So you were mentioning about your early experiences and understanding of the social dynamics linked with the caste and the gender with your early experiences in Tamil Nadu, and mostly in a rural, so-called rural environment. And then you spend a lot of time later in Kerala. So there was like an opportunity for you to have a real comparison on how that difference, how much was that different, across the states, or and what are the probable, possible political or social reasons that you can ascribe to for some of those differences that you might have felt, or wasn't there any difference at all?
Well, there are many, many differences. Access to education is a very important thing. And also, I think Kerala's innate, matrilineal structure and the fact that women owned property, at least in several communities, if not across the board, has made a difference to the way women perceive themselves and their sense of entitlement. That being said, and that's very, very different from the communities that I have and continue to be in some way in touch with the same groups, even today. But the caveat is, can I say, do I think women enjoy sexual and reproductive rights in Kerala? I think there are huge caveats. I think this is true for many places, not just Kerala, many developed countries as well. Today, what is happening in the US, women fighting for, their right to have abortion services. So, it is, these are rights that women nowhere in the world are able to take for granted. Eastern Europe, Poland, with everything available to them, has gone back in huge measures. So I think, Kerala has to recognize that its women are not yet, enjoying sexual and reproductive rights to the extent that they could. And I think I don't know, some of you may have seen it. I had published a paper in the India Forum about women's contraceptive decision-making in Kerala. Based on in-depth interviews. So it was a qualitative study with a range of women, mostly middle class, almost all completed high school and many college educated, could not independently decide on which contraceptive to use and when to use. And definitely, there was no question of the husbands even stepping in to use vasectomy, for example. So it was women going through 2 pregnancies or any number of pregnancies, 2 children, because abortion is also being used. I'm sorry to say, if I don't want anybody to take offense, but I do think that if you look at the statistics, that use of reversible methods of contraception is extremely low, but the motivation to definitely not have more than 2 children is very high. So it's only logical that abortion is one of the means through which family size is controlled. So women have 2 children and then go for sterilization. And men are magnanimous enough to allow women to go for sterilization. So I think many things are different. Qualitatively, health indicators for women are much worse in the marginalized communities that I know of in Tamil Nadu, in terms of nutrition, even in terms of hunger. Things have improved vastly. The communities I'm talking about, it's 40 years ago, and I'm still in touch. Many things have changed, but there is a difference because of the social security, the food security, and other things that exist in Kerala. But sexual and reproductive rights, I think we have to ask ourselves a few questions.
I remember, I have also been part of one of those studies, if I'm right, like that you were, I think probably you were mentioning. And we found that interestingly, like how during interviews, women face it difficult to reveal about those choices in front of their in-laws and other family members. And then later they're running to us, and telling that, no, this is not what I wanted to say. This is the fact that I want to share with you, but I couldn't tell in front of my family members. So even in state like Kerala, there is a big divide, as you rightly mentioned. And also, I think one important thing that you mentioned now was that we should not take things for granted. 40 years, whatever you could change can be, reverted in just one decision, like we are seeing in the US currently, or
Absolutely.
Many things happening in India. So that makes us, people have to be more vigilant continuously and working on a continuous way. So when you said about the sexual and reproductive rights, it's also to see like how people in the public health practice or public health world see these things. So are we seeing that we have done enough? This is something which we already know, and we have achieved what could be achieved, and this is not an area for us to do more work. Is there some sort of an lethargy in the community that not much research is happening in this area, not much understanding?
Well, not much funding for research is available in this area to begin with. So, even for a lot of students and researchers, that is one major roadblock. How many announcements do you see of call for proposals in the area of sexual and reproductive health and rights? There are, even the usual donors for India, like the MacArthur Foundation and the Pope Foundation, are no longer, giving money. And government funding in these areas, I really don't know. So that is one part of it. The other is that somehow, our approach to reproductive health has been about fertility decline. And so when replacement level fertility is reached in any place, people sit back saying, we've done all we need to do. But, I think I have a paper written in 1993, in which I had said that you could reach replacement level fertility with women suffering from a whole range of reproductive and other health problems. So, the reason for replacement level fertility was to ensure women's health. That was the original purpose. Now it became an end in itself. And at any cost, we reach that. And we have forgotten that there are many, it's not just reproductive health, it's reproductive well-being, all the granular elements of well-being, including knowledge. There is no comprehensive sexuality education in anywhere in India. There is so much bias against people of a different sexual orientation, different gender identities. There is no openness to talk about these things. So I think because of our 1-point agenda of reaching, reaching 2.1 TFR, all the states that have reached that and gone below think they have done everything. And they are not even inquiring into all the other things that are actually going wrong in the area of sexual and reproductive health. And I also want to say that we are also looking at aggregates and not looking at gender dimensions. And also in gender, I mean, it's not always just male versus female, it's particular groups of women who are more affected. It's not, all women who are affected. So, that intersectional lens in looking at who is affected, why they are affected, and what can be done about it. And I mean, we haven't even started asking the questions.
I was about to ask about the intersectionality, and right, you mentioned that there. So many often, we have had history of forced sterilization in the past. We had selectively targeting people of lower socioeconomic or specifically in our situation, lower caste and marginalized groups as targets for achieving our whatever you call the rates of population control or fertility rate. So we thought that was like an old chapter, but we see that happening, but in different dimensions. There may be like calls for targeted activities using a different dimension. May not be, there is definitely caste and other dimensions getting added with changing times. So again, but if you look at how public health activists or public health researchers or policymakers, how much are we into using this intersectionality lens? For example, how much we identify the differences in the TFR, the changes in some of those rates using those caste or socioeconomic lens. Kerala, for example, tend to say we have a very low infant mortality rates. Some say 1 digit, 9, 7. Definitely, if you use this intersectionality lens and see like which community or which population is having that infant mortality still higher, it will not only help us to identify where we are, but also will help us to find ways to improve the situation. How much are we, I mean, all of us, how much we could contribute, and what is preventing us from doing that?
I think, one of my recent engagements was in the area of health equity and what has been done on health equity in India. And, Chitra from your institute was one of the major contributors to this. So one of the things we found in that, and maybe there are more publications subsequently, but first of all, studies that have an explicit equity lens, or even looking at, what are the inequities in health are very, very limited. And I am talking about a 2018 publication, so I may be dated with that caveat. And the best of studies, what they did was they described the inequities. They didn't query the inequities. They didn't say what is leading to these inequities, what are the pathways. And unless you know what the pathways are, you cannot intervene. You cannot, the same endpoint could come from many different routes. In fact, I mean, one of my concerns has been that when you just look at data and then you say X group from X state is having very low immunization, and you don't know how they came to have that low immunization, whether they didn't have access, whether there were other health issues, whether, then you start, a top-down kind of program initiative penalizing people who in the first place didn't have access to services. So that is, that's one of the things. I also want to say one or two things from the health equity studies, which, that project, which I think is very important for us to remember. One of my big learnings at the end of that project was, till then, I was also teaching about health equity and health inequities as gaps. And by the end of that project and some studies in the tribal areas that we did, what we realized was that even when you don't see a gap, that is, say, you have tribal antenatal care coverage, 95%, others 99%. What this masks is the price that tribal women are paying to access those antenatal services. They may be walking for several kilometers. They may be foregoing a day's wage. They may be, leaving so many things behind. They may be hungry and coming, and all we see is the data. And that, okay, we have achieved coverage. So there's no problem, but there is a problem. So unless you go to the, to the qualitative elements of what lies underneath the data that you see, I think we will not recognize issues that need to be set right. We may think everything is okay when many things are not okay. Another example somebody gave me was from an IDP camp, internally displaced people's camp in Assam. They said the woman delivered and she had, a live child. This will go in as a safe delivery like any other. But this woman is in the IDP camp. She ran for safety from an ethnic conflict and has lost everything. And with, very few people of her family around her, she has given birth to this. One safe birth versus another, Where is the lived experience coming out is the big issue.
These issues which already and no,
Not clear. It's not clear, sir.
I just want to raise again the same issue. You have worked in the area of safe abortions and autonomy of women. And you are a founder member of a National Coalition of Reproductive Health and Safe Abortion in India, known as Common Health. Do you think women are autonomous regarding reproductive health decisions? You already mentioned, but given this current scenario, even in Kerala, because there are a lot of issues regarding tribals, being raised in Kerala, we have undertaken studies, especially on marginalized communities like tribal women, who still go for unsafe abortions, also under patriarchal dominance. What are the current trends and your own contributions to address these issues, and especially through this organization? Were you able to achieve something through this national coalition?
Okay. Let me say straight off, it's not only the tribal women who lack the autonomy to have a safe abortion. Studies from Kerala, done by other scholars in Achyuta Menon Center, show that a vast majority of gynecologists are unwilling to provide abortion services in Kerala. And this is not unusual. This is also found in many other parts of the country. And I think one person, a very senior gynecologist told me that, she's now retired. She said in those days of population control, we felt that by conducting an abortion, we were contributing to controlling the population. Now I don't have to do it anymore, So I don't know how common this thinking is, but the non-availability and the refusal, turning women back by the health services is an overarching phenomenon everywhere in this country and reported from many other countries as well. So Common Health, one of its concerns, and it's a coalition with the member organizations which are working at the grassroots level, more than 150 to 180 member organizations, all very small, working in very few villages all over India. One of the things is, one of the tasks that we have is to capture the lived experiences of people through, the MG Health, through facilitating these community-based organizations to bring those voices and then use it as material for advocacy, write it up and bring it out. And one of the very well-known contributions of Common Health is a publication called Dead Women Talking. It is about maternal mortality, and data was collected by a large number of community-based organizations. Many of us participated in, in guiding, in making sure that. So we developed the questionnaire together. We did a training on how to use the questionnaire. They brought their data back. These are not researchers. These are community health workers, NGO workers, actually. They brought the data back, and we collated the data together. And then, of course, the final writing up, different people at the levels did. But then each group used it in their own states for advocating and for improving quality of services at different levels. So this is one example of, our commitment to making voices heard, or, those who are invisibilized, their voices need to be heard. In terms of abortion, again, we've done trainings, and there is, tools for community level monitoring of availability of abortion services. And it is from these report backs that I'm telling you that all over the country, availability of safe abortion services are becoming very, very rare. And it is forcing women to use medical abortion pills by themselves to have an abortion, which is also being reported. There are much larger studies that are also, showing this. So this is the main task, to learn together and to use the voices for local level advocacy, for state level advocacy. Mainly, our focus is state level, because each state of India is so different. And it's focused, many of our groups are focused from Western and Northern India and some parts of Eastern India, very fewer in the South.
You mentioned about maternal mortality. So, and just to add on to that, because sometimes, as you were telling, abortions were supported by professionals at some point of time because it helped in population control.
Mm-hmm.
Similarly, there is a sort of a perception that maternal deaths needs to be prevented, not just because we need to prevent maternal deaths, but we also need to stabilize the family size, and then we also need to save the child. It's also related to infant mortality reduction. Now, once you have the delivery and then the maternal death is prevented, you seem to forget the woman. So this I have seen there's an increased interest in understanding the postnatal life and health of women, and there are some really serious work going on here that I know. Are there any studies that you know of, or there are interest in that area of postnatal care for women, at least like a 1-year follow-up of what happens even after they come out of their maternal deaths? How is their health, and do we need to do that?
Yes, we do. And actually there are studies in India done by well-known researchers in Rajasthan who followed up for a year after delivery. And especially, so what happens to women if they didn't die in delivery? Within a year, there is what we call the near misses. There is a very high level of mortality among the near misses during the 1-year period. This is only one study, but what it shows, and that is because of, they may not die from a reproductive health cause, but they come out so severely anemic. But since the baby is fine, or in fact, some of the reasons were that many of the near misses also had poor pregnancy outcome. It was the child had died, or the child was very seriously sick, or it was a stillbirth. If there is no baby, when the woman goes back, the woman gets no care for the, and she is actually pushed into an immediate pregnancy. And this led to complications, and that was one pathway. The other was that they were so severely anemic because of the hemorrhage, and nobody was taking care of them once they went back. I mean, the baby is fine, and so on. Then malaria, other infectious diseases, and the women died. So yes, I think it's extremely important. The other very important thing is postnatal mental health. That I think, in even the very limited study I did in Kerala, we followed up 500 pregnant women through pregnancy and postpartum. And there were many instances of postpartum depression among these women. It was not the subject of my study, but, one of the reasons why they couldn't adopt contraception, which was what I was inquiring into, was that they were deeply depressed. But nobody was paying any attention to this depression. There was even one instance of postpartum psychosis. So there is a very important need for such a study. One MPH student in Achutamenan Center, the only one, she studied about postpartum quality of life among women. And she said from her own experience as a mother, she felt that postpartum well-being, not just health, was not given the attention that it was due. And she used a WHO tool there is a specific WHO tool to study postpartum quality of life. But the reality that I see is that most people don't study reproductive health or sexual health. If they study maternal health, they are studying maternal health programs, ANC coverage, and so on. It's not the human being who is suffering and the motivation to stop that suffering that seems to be underlying these studies. So, standard package interventions, why keep studying ANC when there is a whole load of, health issues that study ANC and, pat yourself on the back, 99% very good. Everybody is doing very well, So I think that you've touched a raw nerve, because I have not been successful as a teacher in inspiring those many people to do studies in reproductive health. Very rare, either gender or reproductive. They may have been somewhat influenced by it, but never took it up for research.
No, I also don't want to, restrict these conversations to, of course, and I want this opportunity to hear you from you also on some of the wider determinants. Of course, I remember some of the conversations during our AMC days regarding, population control versus resource utilization. And this again, when we speak about climate change and, trying to limit utilization of the environment and the resources. But we also, I feel that there is also a tendency to move away from one sort of destruction to another sort of destruction, which is very convenient for us because we will still continue to have all that we want, but, trying to restrict, some of those things that we were really using all these days to some of those sections which are going to start to use it. So, so in that way, how this population control and the environmental disaster, the climate change that we are facing, approaching them from an intersectionality lens, again, the marginalized, the poor who are at, the extreme end of sufferings. So how do we see that, not just reproductive health, but also in health in general?
Well, I was myself thinking that we've spoken too long on reproductive health because that's a passion, but social determinants of health or the larger global structural determinants of, that produce and sustain ill health is a very important issue. Now new names have come up, commercial determinants of health. I think it's very important to look at the commercial determinants of health and to look at, climate change and what is the root of the climate change, not just how is climate change affecting health, but what is causing the climate change, which in turn is affecting health, is very similar. That is the same thing that is causing, food insecurity, and the same things that is causing, huge economic inequalities in countries where, wealth is getting accumulated at the top end, smaller and smaller groups controlling wealth. Now, if all these things persist, what are we talking about? Improving health of people through health programs? And I was just thinking, how much can anybody do to keep people well if, you don't stop all the forces that are, actively throwing, mutilated bodies in front of you, one after the other. You are catching it, rapidly. And you're trying to save what is happening. You have to do that because those who are now sick need to be taken care of. But, we have to do something to prevent, the ill-being of people, and all those structural issues. I have to question to what extent public health education is even touching on these aspects. This is what the Political Economy of Health book by Leslie Doyle almost 40 years ago pointed out, saying that it's the same things that keep people poor, that keep people ill as well, So attention to the larger political dynamics. Again, there is interest in climate change and health in public health. But it's about, okay, there is a disaster, how to do disaster management and emergency health services and how to, fine. These are necessary. I'm not, degrading it, because when people are sick, they want more than anything else. They want, help. But we cannot afford this. Look at any of our states, Kerala, Tamil Nadu, taking care of diabetics, not preventing diabetics, diabetes. How much can we do, And people are, getting increasingly, vulnerable, more and more people moving towards dialysis and, kidney failure. So then we set up more dialysis centers, more super specialty places at lower levels. Okay, but when are we going to start the other thing? We haven't even started.
Well, you have already mentioned about political economy of health.
Yes,
Not
sir, can
able to
you
hear,
please,
sir.
Yes,
please come closer.
you have already mentioned about political economy of health, and especially Leslie Doyle's work. That's a favorite area. Especially some of us have been trained in this political economy model long time back. I know you are not a blind believer of hard data, but at the same time, evidence is also required to evolve public health strategies. And this is especially evident during the present pandemic times, where most of the decisions, not most, many of the decisions are taken on the basis of some experts sitting in meeting rooms, what we call as eminence-based decisions. And this is becoming very prominent as against evidence-based approaches. I mean, the young scholars here would like to know what are some of the major limitations of data and evidence in Indian public health. Because as a health economist trained in data, you are the best person to advise the younger generation.
Well, I think I'm not an unbiased speaker in this regard. And therefore, let me just say, I do believe that we need good quantitative data and large scale data. But the problem that I'm seeing is that data should not set our parameters for what we should be studying. So, so what is being studied is, in many, what are the health issues being studied depends on whether there is data in NSS or NFHS or now national health accounts or something else, and other areas don't get, covered. So to that extent, what data is needed, who decides what data is needed? And who acknowledges, that certain data, certain kinds of data are robust. And one of the things I think we forget is that quantitative data is also collected by individuals. Now more and more with artificial intelligence, no. But yeah, quantitative data is also normally surveys collected by individuals and shared by individuals, and therefore subject to all the biases on both sides. I decide what I want to tell you, and you interpret it and write it down in how you understand because of who you are and how you see things. So the limitations of quantitative data are never inquired or queried and challenged. That is one issue that I'd like to say. The other is that if we need to go, and we do, go beyond the what questions, what is the pattern to why something is happening, then we need more than quantitative data. We need qualitative and granular information, and we need to know how best to combine the two to take informed decisions. We also, have to look at, what do you say, in terms of the, the politics of evidence gathering. Who decides, as I already said, who decides what counts as evidence, and who acknowledges and gives it the gold standard? Would data collected, like we said, for dead women talking is always, I mean, it's, people are always going to question about, oh, this is coming from, untrained community level voices. But I guess we need to recognize that there are different kinds of evidence, and all these have to be used together in a judicious way, so that we get the best results. But as I already complained, what we are now doing is not querying what we need to find out, but we are deciding our questions on the basis of what data has already been collected, and therefore, so I will look under the light for my keys because, I may have lost it elsewhere, but this is where the light is kind of approach to data and evidence. And the terminology of citizen-generated data is gaining prominence in the UN circles. And the UN Women has done quite some work in COVID times in gathering information from communities. It's not just rural communities, rural, urban, other marginalized communities, middle-class citizens, and so on, to really get a hand on the pulse of what are the various things that are happening and that needs to inform, interventions for the prevention, for, and for increasing uptake of vaccination, and for ensuring proper adherence to preventive behavior, mask wearing or, So unless we really know why people are breaking those rules, we will not be able to change it. And that is evidence too. We need that kind of information.
I think this is really the most important information or knowledge that I think is being shared today. Like, looking for different forms of evidence. I remember we used photo voices and giving cameras to children and women to go out and share with us, like what do they experience. I think it's important lesson for also some of the scholars who are listening today. I'm like taking a couple of questions. We have a lot of questions coming in. So one is like, it's related to like how our health facilities are, the birthing environment, and then the related psychosocial support in the hospital, maternity wards, or labor rooms. I think NASA had also done some work across countries on that. So like, that's again one area which is like less research because of the difficulties of getting into them. And personally, being a doctor who have worked in labor wards, and I know that it's really pathetic, and there's a huge, even in states like Kerala. So how do we see, and what can we do to understand more on this, and maybe also like how we can improve the support system in such hospital environments?
I think the black box here is what makes those health workers behave like that. They are not bad people. I have seen some of the most sensitive doctors transformed when they are, in labor rooms or when they are performing abortions, abortions without pain relief, is the order of the day in many government hospitals. And these are not cruel doctors. So I think we know now enough about the kind of abuse that is happening. I think the big question now is to find out what is making the healthcare providers, from nurses and ayas upward, to behave in that way, especially in the labor wards. They are not as cruel even in the casualty. So there is an element of gender there. There is an element of power, control, a whole lot of things, irrespective of, women doctors are behaving badly, so, and they are not bad doctors. Many are good friends. So I think it's a big issue
to explore. Another thing, like, from an intersectionality perspective, we hear a lot of discussion on the caste census and not doing it and against it. So what is your take on the socioeconomic and caste census and the states being given the power to identify the OBC and its impact on health equity?
These are two different things. The socioeconomic and caste census, if you remove the politics of it, a socioeconomic and caste census is a must for any country. But I don't want to comment on how it has become vitiated and what is included in which caste is becoming the big political issue. But I also know that this is not unique to India. There are several African countries where I've heard friends say that, census is, one of the big issues in the census is enumerating who belongs to which tribe. And what that would mean in terms of exercising political power and muscle, you know. So yes, we do need to know, you know, but not in these kind of fluid categories of OBCs. Today you are one caste, tomorrow you are in another category, and so on. So I will stop with saying that it is absolutely important to have that information. But how easy it is to get that information, whether it can be not politicized, these are very difficult questions, because caste identity is politicized. And yeah, I guess we'll have to learn from other places about how best to go about this.
So maybe before we move to the last, so I mean, you have been part and contributed to the first social determinants commission, and 10 years, much have happened, a lot of improvement, still a lot need to be done, and we are talking about the sustainable development goals. So how do you think, what more should be done, when we see the social determinants commission's work and the global response to that, in this 10 years time?
I think social determinants of health was a very, very important milestone, but I don't think it has permeated into policy making. Which is why I absolutely, was quite taken up with the work of the 3D Commission and so on. It needs to permeate policy making. It hasn't, except in a few countries. And yes, there are the usual problems about convergence across ministries and looking at things and so on. But I mentioned in my conversation with the 3D interview, I think in places where there is good decentralization and there is local government, there is scope. Is there the political will is the question. There is scope for convergence and for actually addressing multiple determinants at the level of the panchayats and at the level of the districts. And those are good units. So much scholarship has advanced, and there has been little advance in terms of changes on the ground, even in terms of paper policies. Forget about, actual implementation.
Let me ask the last question. A lot of young scholars are now working in the area of gender, reproductive health. Would you like to give some advices, as I find most people just approach this area, from a program point of view and very mechanically. I'm not taking an integrated perspective.
Well, my advice to young scholars about any research is, don't research issues that you don't have a passion for. You have to want to know and to bring about change. This is not just a career. It's not wrong that it's a career, but it is not just a career. We have a larger social responsibility. And as people with privilege who know and who have the wherewithal to inquire, let us make some difference. Let us not just, be rooted in where am I going next and what am I retiring as. Let's try to make a dent somewhere and see that things really change for the last person on the ground. Research will always be fun, and you will always wake up every morning looking forward to doing things, if that's your approach to life and to research. Thank you.
Okay. Before I close, let me make one announcement. On 21st of this month, same time, we present Professor A. Venkataraman, an eminent expert in health management from the University of Delhi, in this public health biography series. Professor Sundari Ravindran, thank you so much for the excellent interaction. It was a wonderful journey. And in this short time, we could go through your extremely creative and productive professional journey. I am sure some of the younger scholars present here really benefited from your interaction. And I wish you many more years of creative contributions to public health. Let me extend a sincere thanks on behalf of all the participants here. Thank you so much.
Thank you, sir, and thank you, Shafi. This has been
Thank you so much.
Nice sharing. Your questions were very provocative and interesting. So thanks a lot for everything.
Thank you.
Thank you for joining.
Mm.